Good morning, everyone. We will get started in just a few minutes. Heather, do you mind telling me, can you see the main screen? Okay,
Yes.
perfect. Give everyone a chance to get logged in here. Did it go away?
No, we can see it.
Sorry, it's for some reason this part is. Hold on, let me. Oh, oh, there we go. Sorry. Okay. Good morning, everyone. I see people still logging in, so we'll give everyone just a minute or two here and then we'll get started. We do want to let you know that this webinar is being recorded. If you do have any concerns with being recorded, just please let us know either in the Q&A box, or you are always welcome to send us an email as well. Again, welcome everyone. We're glad that you're here. I am Shalia Quillen, the First Steps Infant Case Management Program Manager, and I will let Heather introduce herself.
Hi, good morning. I am Heather Wire, and I am the First Steps Maternity Support Services and childbirth education program manager, as well as the substance using pregnant people or SUP hospital inpatient program.
We have a wonderful presentations today that we are very excited about. We have a presentation on the Parent-Child Assistance Program and the Washington Plan of Safe Care. We will also provide some First Steps program updates and reminders, and then we will have time for questions and any other just wrap up and kind of extra questions that you may have. And we are so excited to welcome our presenters. So let me, sorry, I added an additional screen for the webinar so it would help me, and I'm trying to navigate between all of them. So, all right, so we have Sarah Pine. She is a behavioral health program manager for pregnant and parenting women services and special projects with the Division of Behavioral Health and Recovery under Washington State's Healthcare Authority. In her work, Sarah supports programs and services that assist Washington State families to receive thoughtful and family-centered care in aim of recovery. We have Ms. Kate Ajayaboa. She is a passionate advocate for equitable maternal and child health systems. She holds a Master's of Public Health from the University of Washington, where she completed and published her thesis on community-based midwife care during COVID-19. She has held professional positions in various sectors spanning higher education, research, and state government. Kate is also a certified birth doula and draws on her previous work with birthing and postpartum families to inform her approach to her current role as a manager of perinatal partnerships at Within Reach. She believes that all families should have access to comprehensive, culturally competent care and services, and is deeply appreciative to those who strive to be part of the collective solutions and collaboratively build a better future for generations to come. We have Miss Sarah. She serves as the Family and Community Navigation Administrator at the Washington State Department of Children, Youth, and Families. In this role, she focuses on strategic planning and implementation of Help Me Grow Washington, a systems approach weaving together state and community systems, providers, and resources to offer a full spectrum of supports to all families in Washington State with young children. A champion of targeted universalism, she works to develop unique pathways for populations of focus while pursuing a universal goal of promoting family resiliency, well-being, and protective factors for all Washingtonians. All right. And we are so excited to have you. And I am going to turn it over to Sarah and Kate. So give me just a moment to do that.
Thank you, Shalia, and thank you, Heather, for having us. And Kate's going to work on pulling up the slides. But hi, good morning, everyone. I'm Sarah Holdener. I work at DCYF, and thank you for the introductions there. Kate and I are going to spend the next bit of time going over an initiative coming out of DCYF that's driven by CAPTA legislation, and CAPTA stands for the Child Abuse Prevention and Treatment Act. And we'll get more into this, but essentially this legislation requires a plan of safe care to be developed for all infants affected by substance abuse, withdrawal, or fetal alcohol spectrum disorder. So we're going to spend some time providing a very quick overview of that federal legislation and what it meant for Washington, and how Washington has opted to implement these changes locally. So we'll go ahead and get into that. Okay, thank you, Kate, for getting those ready. So plans of safe care have actually existed for some time now in legislation. And in Washington State, this work lived solely within child welfare, meaning that these supportive resources and services that are part of a plan of safe care, they were only being provided to families receiving child welfare intervention. But that is changing now. So back in 2016, there was the launch of the Comprehensive Addiction and Recovery Act, which is CARA, and that resulted in changes to CAPTA, or the Child Abuse Prevention and Treatment Act. And this is the legislation where the plan of safe care lives. And so what those legislative changes did is they further clarified which infants require a plan of safe care, essentially changing it from infants who are prenatally exposed to illegal substances to infants who are prenatally exposed to any substance with abuse potential. So effectively acknowledging that exposure to both like illegal and prescription drugs can have the same impacts on the newborn as illicit drugs. So they struck that word illegal from the legislation, and it effectively broadened the population that requires a plan of safe care. So this means now that we have plenty of families who fit that criteria of requiring a plan of safe care, but don't fit the criteria of child welfare intervention. So we sort of have this new population. So along with broadening the population, the federal legislation changed the data that states needed to report to the feds around plan of safe cares. The focus shifted a bit so that the plan of safe care became more family-centered and focused on the needs of the infant and the caregiver. And lastly, there was some language around how the monitoring and oversight from the states needed to look. So that is that's kind of this driving legislation around this initiative coming out of DCYF. Okay, so this legislation came down, and now Washington as a state needed to figure out, how do we make this our own, and how do we want to implement it in Washington State? So way back in 2017, we began partnering with a technical assistance partner, the National Center on Substance Abuse and Child Welfare. And for effectively 3 years, from 2018 to 2021, Washington worked alongside our TA provider to engage cross-sector stakeholders all across the state in order to really come to agreement around what this legislation would look like in our state. For instance, we had to do some work around defining the language within the legislation. So how did Washington want to define the statement affected by substance abuse? So we, for 3 years, we all worked together to come to agreement around those definitions. Washington also needed to clarify the notification and reporting pathways. And we'll get more into this, but most states, it's one and the same. They don't have a notification process that's separate from their reporting process. And that reporting process is for child abuse and neglect. But Washington opted to separate them and implement 2 pathways for the plan of safe care. And so there's a reporting pathway, which is when a family receives a plan of safe care through child welfare, and a notification pathway when a family receives a plan of safe care through the community. So Washington as a state needed to then just define and determine that criteria for each pathway. And then finally, our last pre-implementation task was to identify a sustainable system to oversee both of those pathways. Okay, so this is sort of where we are in the timeline of the work. I went over preparation and design. That was sort of the pre-implementation work. In 2021, we did launch 2 pilot sites, and we also stood up an online referral portal. And this is the mechanism or the way that hospital social workers refer a family to a plan of safe care. We'll get more into that later. And so effectively, since 2022, DCYF, in partnership with Help Me Grow, has been working really hard to engage and train birthing hospitals across the state around the plan of safe care and the changes associated with it. We've also worked to update policy in child welfare to align with the plan of safe care. And then earlier this year, DCYF and DOH sent out a cross-agency memo requesting that birthing hospitals update their policies to be in line with the plan of safe care by early 2025. So that's the timeline now that we're all working towards. Although I just want to take a moment and highlight that although the plan of safe care is really being is held within DCYF, it's been a deeply collaborative project. We've coordinated with state level agencies, including Healthcare Authority, Department of Health, Help Me Grow. The Washington State Hospital Association has been a key player, and really just a multitude of community partners and providers. The plan of safe care is a recommendation of both the Washington Opioid and Overdose Response Plan, as well as the Washington Maternal Mortality Review Report. We're also getting a lot of national recognition. The way that Washington is implementing 2 pathways, right? So that not all families are funneled through child welfare, but rather there's this alternative community response is somewhat unique. And so it's really being held up as an example for other states to consider to see if that would work in their states as well. And finally, there's a lot of lived experience and family voice driving the work. The plan of safe care is the largest project in Washington's CAPTA state plan, and there are 3 citizen review panels associated with that state plan, and they're all weighing in on the plan of safe care. And then just a moment to highlight that although this is really the plan of safe care, this legislation and the subsequent policy changes that are happening and practice changes, it's really looking at systems level change. And that includes some examples here are looking at hospital policy and procedures and the opportunity to think about when are we, can we promote universal screening? And when are we deciding to test newborns? When are we deciding to refer to CPS? And really looking at best practice with this population. With the establishment of the online referral portal, it's given us an opportunity to, through healthcare providers' input, really think about a shared understanding of safety concerns, and I'll touch on that in just a second. We've also integrated a bias checkpoint. And then alongside all this work, we've also been updating our mandatory reporter training to really center anti-bias and the family experience and to be in line with much of the changes that the plan of safe care is driving. Excuse me, I'm fighting a cold. This slide is really to just, DCYF really wants to promote to all healthcare providers that the process of pathway determination and whether you end up referring the family to CPS or to the community pathway, that should really be a transparent conversation with the family, and the family should have an idea of what to expect on either pathway. And finally, we always stress that to our healthcare providers when we're doing trainings with them, that the verbal consent for Help Me Grow is super important, as we have sort of a workaround in the case that if a family is routed to CPS and actually screens out, that DCYF intake person can reroute the family to the community pathway so that they're not lost in the cracks. Okay, so let's talk about who needs a plan of safe care in Washington. So this is the definition here. So any newborn who has experienced prenatal substance exposure, newborns who are affected by withdrawal or the range of effects identified by FASD, or known prenatal alcohol exposure. So all those newborns require a plan of safe care. Some of those newborns, depending on the criteria, will receive the plan of safe care through child welfare. Some of those newborns will receive a plan of safe care through the community-based pathway, but all require a plan of safe care. I won't spend too much too much time on this, as I think Kate is going to go a little bit deeper into this in her section. But I wanted to just provide an overview of how this whole how this works. So essentially, we're currently in phase 1, which is really focused on birthing hospitals. And so the birthing hospital provider, typically a social worker, sometimes the nurse, identifies an infant as substance exposed. So then they can log into the referral portal, which is essentially like a secure web form. And the provider provides de-identified data related to every instance of prenatal substance exposure. And this is really important because it's helping Washington get a better understanding of the landscape of prenatal substance exposure in our state. Excuse me. So that de-identified data is input and automatically sent to DCYF. And then this portal has a decision tree built into it, and it helps the provider kind of walk through some questions and circumstances and identify, is this family most appropriate for the child welfare pathway or for the community pathway? So if CPS is most appropriate, they're instructed to call CPS. There's no real changes there. But if the community-based pathway is most appropriate, they're then sent to a separate screen, and it's a referral to Help Me Grow can be made if there is verbal consent in place from the family. We've done a lot of work over the last year based on healthcare provider input to really ramp up the online referral portal, and to develop to try to strengthen the shared understanding of safety concerns. And I think the gist is that it's not black or white, right? And we all know this, but it's really weighing those risk factors and the protective factors and the family's strengths with the risks they're seeing. And so it's really important to understand the whole picture, and that requires conversations with the family. Thank you, Kate, for moving slides. Okay, so let's talk about when that community pathway is appropriate. So here are some examples, and I'll just read one or two. One might be that a healthcare provider verifies that a birthing parent is taking methadone or buprenorphine or any other opioids as prescribed, and there are no safety concerns. Another one is that a newborn is prenatally exposed to alcohol or cannabis, and there are no safety concerns. So you can see that there is still this requirement that there must be no safety concerns, and that we ask that the healthcare provider is able to verify that the parent is taking their prescriptions as prescribed. But these are just some examples of how the community pathway is appropriate, and that decision tree embedded within the referral portal really helps that healthcare provider make those decisions. excuse me. The plan of safe care, whether administered through child welfare or through the community-based pathway through Help Me Grow, really works to holistically support the family and the infant. And you'll see some examples of some of the resources that are provided to families through either pathway. It's just that when it's administered through the child welfare pathway, there's going to be a focus on really assessing that risk and safety. Whereas when it's administered through Help Me Grow, there's more of a focus on these set of core essential services that Kate will get more into, as well as long-term recovery supports and local connections and local provider supports for those families. I'm almost done here. Just wanted to give an example of the data that DCYF is required to report to the feds. So it's not that substantial, but it's the number of newborns requiring a plan of safe care, the number of plan of safe cares that have been completed, and those that included a subsequent resource or referral, as well as some de-identified demographic data. Okay, I'm going to pass it off to Kate, and happy to take questions if there's any in the chat around some of that background.
All right, thank you, Sarah. And how are we doing on time, organizers, just so I know?
It is 1:22. You are doing just perfect on time. You take whatever time you need.
Okay.
Any questions now in the Q&A, but please, participants as questions come up, please put them in the Q&A box. Thank you.
Wonderful. Thank you, Sarah. So now I'm going to talk about the Plan of Safe Care community-based pathway provided by Help Me Grow Washington. And yeah, I'm Kate Ajiaboa, as Sheila said, and I'm the Perinatal Partnership Manager. And I work very closely with Sarah in training the hospitals and kind of rolling out this work. So you heard a lot about the sort of DCYF side of Plan of Safe Care and what that looks like. And Sarah did a great job of setting that up. So now kind of diving into the community-based pathway and what is Help Me Grow, who is Help Me Grow in general, and then talking about what makes this pathway special and specific within Help Me Grow. So you've probably heard of Help Me Grow Washington, and Help Me Grow in general is a free resource focused on resource connection for all families in Washington. And while the service is primarily designed to support families with young children, specifically ages 0 to 5, anyone can connect with Help Me Grow regardless of age or household makeup and demographics. We really do our best to support anyone that needs resource connection and support. And there's no income eligibility or requirements to access our resource navigation. We also have some different support that we can help providers with. We can screen their clients or patients for benefit eligibility. We can start a benefits application for lots of different services and benefits over the phone with people. And we can email local resources like WIC clinics, food banks, and other things, and send that information to providers and their clients. And Help Me Grow offers, in general, 2 types of resource support. So the first being information referral. Like I said, we can compile lists of different resources available in people's community that they might be eligible for, if that makes sense to them and they just want to know what's out there. But we can also provide those referrals as well and actually do that over the phone with people. We can also do screening and enrollment for different benefits, like I said, different health benefits, basic food, Orca Lift, and things like that, and actually enroll people in those benefits. And Help Me Grow focuses on 4 essential service areas across the state. And those are access to adult and pediatric health services. So like I said, health insurance, getting healthcare and things like that, access to food security supports, access to child development supports and screenings, and things like that, and then access to family support. So that could be baby supplies, transportation, goods and other things like that. And so, as Sarah said, the Plan of Safe Care is this overall umbrella that encompasses both the report to DCYF's child welfare, so the kind of CPS pathway, or a notification to DCYF with that aggregate data that's sent to them, but then a voluntary referral to Help Me Grow, the community-based pathway. And so we're kind of one of the two different pathways. And what makes this pathway unique is that the plan of safe care clients that are referred to us go to our statewide mental and behavioral health team. So there's a specialized team that supports this population, and they do things a little bit differently than the Help Me Grow general family resource navigators. So this is just a unique way to access our services, and it's a little bit different. So what makes the plan of safe care community-based pathway unique as opposed to general Help Me Grow, which families can call? So right now it's exclusive to birthing hospitals. As Sarah said, the state has a goal of getting all of the birthing hospitals trained and using the new system by January 1st. And we've trained almost 40 of the 54 birthing hospitals. So we are definitely well on our way, but currently really pushing to get every hospital onboarded. And those providers at the birthing hospital are who are making these at the moment. And then, as I said, the specialists and family resource navigators that support this population, the mental and behavioral health team, have a different outreach and follow-up structure. So they're just a little more robust and flexible depending on the needs of the family, the way that they follow up. And they can also get consent to text and email with clients, which is really a great resource as well. And then they focus on the unique needs of families with substance use or substance misuse. So they kind of have specialized training and specialized resources to support this population. So this looks kind of similar to the slide that Sarah shared about the resources related to Plan of Safe Care offered to Plan of Safe Care families. And there's a lot of overlap between the CPS pathway and then this pathway. But there are some, just to kind of highlight what we do at Help Me Grow. So on the left side, in purple, the Help Me Grow general support. Like I said, we do things like application assistance for benefits, housing resources, home visiting, early intervention resources, parenting support, childcare, infant supplies. And all of that is available to the Plan of Safe Care families. But then in blue are some of the additional offerings that we are very frequently offering and supporting the Plan of Safe Care families with. So things like substance use treatment, peer mentorship, mental health resources, postpartum depression support, safe sleep information, IPV support, and lifeline phone services, so free cell phones. That is a really popular resource as well. So it's just kind of additional things that are available through this pathway. So we like to highlight a family story just to kind of show how this works in action. Both of the family resource navigators that are on the mental and behavioral health team are bilingual native Spanish speakers. And we also have access to a language line, so we can support families with different language needs. And in this case, one of our specialists, Carla, had a Spanish-speaking family with mom and dad and 4 children that she was able to support, and just kind of sharing some of the things that she was able to help with. So this family was already enrolled in Orca Lift, Washington Apple Health, and WIC. But during the intake, the mother was able to really talk with Carla and share that she was struggling with anxiety, depression, and just all of the difficulties that come along with being a mom. And Carla was able to connect this family to baby supplies, MSS, and behavioral health services, mental health hotline, perinatal support Washington, employment training, PCAP, and then also was able to get the family connected with PFMLA, and was able to enroll them in the SafeLink wireless for a cell phone. And then just some of the quotes from the mom shared. She was able to talk about her past and Carla made her feel comfortable to share. And she felt comfortable speaking with her and really appreciated her help and kind of called when she received her cell phone. So showing up and delivering on these things is really important. And yeah, that's what we have. Any other questions about the community pathway? I would love to answer, or Sarah can respond about the DCYF pathway. And yeah, just a plug for our community of practice, which we have once a month, and kind of talk about plan of safe care and relevant topics and things like that. So thank you for listening. I think there's a few questions in the chat. Oh, Sarah, thanks for answering.
Thank you.
You're welcome. I was like, I think I got them all.
Yes, great questions. Yeah, Alma, that's a great question about which hospitals are implementing. Yeah, the DCYF's webpage is pretty up to date. You know, we have had several in the last month, and we have several that are scheduled for November and December. So, yeah, you can always email me individually if you have like specific questions about your county, because things change. And even if a hospital was onboarded, we do find that because of turnover and just getting the word out and the process rolled out in hospitals is quite the lift. And so a lot of times people need hospitals will need another training because there'll be so many new staff members and things like that. So it's kind of, even if they have had the training, it might still not be being utilized all the time. So just kind of a moving target, I guess.
Thank you. And Sarah, if you don't mind, I don't believe that all the participants were able to see the questions. And I do think those are wonderful questions. Do you mind kind of summarizing, just because those are great questions, so I think that some other providers may be interested in knowing those as well, if you don't mind.
Sure. So there was a question around, can a provider refer prior to delivery in the hospital? And my response was that the plan of safe care is really designed for at birth, substance exposed newborns. However, we all recognize that moving upstream is the smart thing to do. And many states have started to implement prenatal plans of safe care. And Washington is right in line wanting to do that as well. And we've actually, DCYF, I think it's been about a couple years now, maybe 18 months, has been piloting it's very parallel, same families, just on the same continuum, just a little bit earlier during birth, starting with families pregnant people who are using substances are often reported to CPS. However, that doesn't qualify for a screen in because the baby isn't born yet. So we're working with DCYF intake to route those families who would normally just be kind of like, okay, you don't screen in, bye, to be routed to voluntary supports through Help Me Grow Washington, and also a hub of partners. So it's a little bit different than the plan of safe care, but it's pretty similar in that that families are driven to Help Me Grow, and a hub of partners in different counties throughout the state who are offered voluntary supports. So this work is newer, and we're not quite as we haven't reached statewide scale, but it is happening, and there's so many opportunities to partner with healthcare authority around this kind of work. So I'm really excited about this body, and we'd love to come back another time and go more into depth in the pregnancy pathway if people are interested. There was another one around safety concerns. And so I had just typed in kind of just a good reminder that if a hospital provider ultimately decides that a call to CPS is appropriate, that it's really DCYF intake and their screening process that will determine if that family indeed screen in or screens out. So sharing what you know about that family's risk factors, protective factors, their situation is going to be really helpful to that intake case. But families will be screened in for CPS when the information provided determines a high likelihood that the infant could be abused or will experience neglect or severe maltreatment as a result of parental substance use at the time of hospital discharge. So that's kind of like if you had to put it in a sentence, that is what we'll screen in. And then I think there was one around how can people find out what hospitals are trained? And as Kate said, it's on our Plan of Safe Care DCYF webpage. think that was all.
Yes, I have a question, and I may have missed it. How long is someone part of like this plan? Like how long are they followed? How long are they kind of like, I don't know if followed is the right term. Um, like how long are they a part of this process until they're kind of no longer needing this additional assistance?
Right. I'll answer for the child welfare pathway. So that's when a family's they've been screened in, and they're going to receive a plan of safe care through their child welfare intervention. And then Kate can talk about the community-based pathway because they are different. So when a family screens in, the plan of safe care is part of their safety planning. It's a component of the child welfare intervention work. So it really follows the family throughout the case, and that can last some as short as 30 days to 90 days or longer. So it just kind of depends on that family's instance, but it's different with the community-based pathway.
Thank you.
Yeah. Yeah, just for the community-based pathway, I was just finding this slide from another our hospital training. So the navigator will reach out to the person within 40 business hours, so 2 days typically, and then they'll make up to 3 attempts to connect. Rarely does someone pick up the phone, the first time, because it's so close to the birth event, but typically they'll have success in the subsequent attempts, and then the navigator will check in with them 2 to 4 times to ensure their needs are met based like in 2-week and 4-week intervals. But once they have that relationship, it's really flexible depending on what the family needs. So we have some like families that have been like, can you call me once a month for 6 months to check in? And, we're not like case managers, but we do like want to make sure their needs were met. And some people want that kind of more ongoing support. So we have had that happen, but typically after the 2 to 4 times, they're like, okay, like I was able to access the resources. I'm good, thanks. So it kind of depends, and it's pretty flexible based on what the family needs. And in some cases, they haven't been ready at that point to work with us and get connected, and then they'll call back months later and they're like, okay, I'm ready now, and we're able to support them in that case.
Wonderful, thank you. I do see another question. Someone is asking, is there a time frame to receive services or program time span, and are there plans to evaluate this program?
Yes, I feel like Kate sort of went over the program time span. It's very flexible, but let me know if there's further questions around that. And yes, of course, evaluation is a huge part of our work. It's interesting. We are already seeing there's been several policy changes that have happened at once, including House Bill 1227, which is the Keeping Families Together Act, which was implemented at the same time as Plan of Safe Care. But we are seeing a decrease in the number of both intakes and out-of-home placements where parental substance use is a factor. So far, we're very excited about what we're seeing with the Plan of Safe Care. We are, as we're kind of reaching statewide scale, we're excited to also look at evaluating the community-based pathway part, right? That the part that Help Me Grow is working on. And like, how is that being effective? And we're having a lot of qualitative stories, but we're now working on an evaluation plan for the community-based pathway piece as well.
Wonderful, thank you. It looks like that is all of the questions that we have now. Sometimes we do get questions that come later. If you all don't mind, sometimes we'll email you afterward if there's some questions, if that's okay.
Of course.
Wonderful. Thank you so much. We really appreciate it.
Thank you. And I'm just going to transition to phone. I got to pick up a sick kiddo, but I'm excited to hear Sarah's presentation.
Wonderful. I am going to go ahead and share my screen and turn it over to Sarah Pine to talk about the PCAP program. So give me just a moment here.
Thank you, Shalia. Hi, everyone. My name is Sarah Pine. I work for the Division of Behavioral Health and Recovery under the Healthcare Authority, and I manage a bunch of different little contracts and big contracts. And one of the bigger contracts is the Parent-Child Assistance Program, also known as PCAP. I want to start by saying thank you to Shalia for being willing to present my slides for me. I'm having some technical difficulties, and that's why my face isn't being shown because I'm using my cell phone. So I apologize for that component being missed here, but I am grateful for Shalia's help. I will get into it. So we can go to the next slide. Thank you, Shalia. So the Parent-Child Assistance Program, commonly called PCAP, is a 3-year intensive case management program that is currently offered with 15 contractors statewide. In total, PCAP, I'm sorry. In total, PCAP is serving 20 counties. So some of those contractors are serving multiple counties. And we serve about 1,500 client slots statewide so far. The program is funded with both Medicaid and state dollars, and DBHR has service level agreements with both ESA and DCYF to support PCAP services dedicated to both TANF/Work First enrolled clients as well as DCYF involved clients. Next slide, please. So the PCAP program offers clients referral, support, and advocacy for substance using disorder treatment and continuing care. PCAP case managers work directly with their clients to support individual needs, which can include linkages to healthcare and appropriate therapeutic interventions for their children. You can see on the screen here that there is an array of individual needs that a client may have, which ranges from family planning all the way to legal services and everything in between. Next slide, please. So the University of Washington, what do they have to do with PCAP, you might be asking? Well, the Addictions, Drug, and Alcohol Institute, also known as ADAI, which was formerly the Fetal Alcohol and Drug Unit, FADU, actually offers we contract with them, DBHR contracts with UW to support PCAP sites around the state with quality assurance, implementation, fidelity, staff training, and also data collection and evaluation of the program itself. They provide DBHR both monthly PCAP updates in like small data reporting and also annual PCAP reports that are a larger array of data, including a demographics report, which is fabulous to understand the population itself. The demographic report does contain data in many areas, some being like client background, substance of choice, domestic violence experience, and number of births, is just a few notes to take away from what you may find on there. You can find the demographics and their annual reports on the HCA website, and I'd be happy to share links to that if anybody is interested. The last couple of years are available on our website. So some PCAP history. You know, this is quite interesting. PCAP was originally an original study from UW in the mid-1980s. UW researchers under the Fetal Alcohol and Drug Unit, FADU, they received a federal grant to study the effects of prenatal cocaine exposure on infants and young children. And this sparked an interest in what would happen if they focused some support and work around mothers. So in 1991, a Substance Abuse and Mental Health Services Administration, SAMHSA, grant supported the development of testing of the PCAP model because UW applied for that grant and received it from the director of Therese Grant, Dr. Therese Grant. And Dr. Therese Grant was the director of PCAP. She built the program model and oversaw the program model for many years, and began doing the work of what is now ADAI, which is staff implementation, training, and fidelity oversight and data collection of the program. She oversaw all of that up until a few years ago when she retired. And so the program has been steadily going since 1991. And now you can go onto the UW's website itself and look up some of their reports and publishing on the PCAP program or data that they kind of witnessed through the PCAP program and kind of saw something about the population itself through that information. And they have quite a lot to share if you're interested. Next slide. Thank you. Oh, sorry, you're on it. So how to make a referral. So this is quite a simple, sorry for the screen. I know it's not as clean and fun as some of my other slides, but the eligibility is like a 3-part step, basically. So if a woman is eligible for the program, they engage in at-risk use of alcohol and drugs during pregnancy. They're pregnant or up to 24 months postpartum, and they need help connecting to recovery supports. Also, they made some adjustments to the eligibility in the last several years and include that if a woman has a child with a diagnosis of FASD, they're currently using alcohol and drugs and are in their childbearing years, they can also be referred and eligible into the program. There's a referral page on the UW's website, which is linked on this slide. I don't know if our slides are going to be shared out, but I can also provide a link directly if anybody is interested. And so you can make a referral using the UW's website, or you can connect to a site directly if you're familiar with one in your area. Many times the referrals are done by community partners that do similar type work or work with similar populations. So they're very well connected to one another in their communities and are familiar with PCAP and know that PCAP can, take in clients that have those eligibility criteria met. There's also a huge wave of self-referral in PCAP because of word of mouth. So friends of friends or family members or people in similar type resources that access similar resources in their communities. PCAP is just really well known through word of mouth, and oftentimes clients will contact the site themselves to get support. Thank you, Shalia. So DCYF is a huge supporter of PCAP. We, as you heard in the last presentation, there's a connection between the work of DCYF and PCAP in lots of areas, but specifically DCYF, sends DBHR biannual service level agreements, and those service level or interagency agreements basically give us funds to include into some of our PCAP contractors' contracts to dedicate specific amount of client slots for DCYF involved clients. So the funding that comes from DCYF opens up slots for DCYF involved clients that are enrolled in PCAP, which is pretty incredible. So far, we have 4 sites that are participating in this agreement. We've got Clallam Jefferson, which is one site serving multiple counties. We've got King, Yakima, and Spokane. So currently, each of these sites dedicates 14 client slots. I mentioned on the slide here that there are new amendments underway, which is kind of a cheeky way to say more client slots are being dedicated at the moment in amendments to some of these sites. So there will be more clients being served under this agreement here pretty shortly. Next slide, please. This is some background information on recent legislation that was passed to help support PCAP. So in recent legislation, funding was provided to expand PCAP client slots with DCYF. As I mentioned in the past, this was a DCYF initiated decision package. So it resulted in the expansion of client slots by the end of fiscal year 2025, which I mentioned we're working on. And I believe at this point, the estimated start time of the expansion is within like the next month or two. So you should see the client number of served clients total statewide increase by January of 2025. That's our goal. Next slide, please. Another legislative effort that was passed was a series of rate increases that supported the PCAP programs. And our last rate increase was effective January 1st of 2024. It included a 15% increase, which is fabulous for our providers. Many of you probably are very familiar with the struggles that providers in this service type are experiencing with workforce shortage issues or the lease rent increases and cost of living increases just are really putting a strain on our providers. And rate increases like this are helping our providers, our PCAP providers, get more funding without having to serve more clients or hire more staff. So it's just extra funding that supports the rates to the work that they're already doing, which is very, very helpful, especially in this time. Next slide, please. Thank you. So if anybody has any questions, I'm very happy to answer them today. You're also welcome to connect with me by email, which you see on the screen here. And I'll let Shalia help wherever necessary.
Cool. We do have a few questions, and I think you may have partially answered some of these. A question, I would like to know how to get a PCAP program on the ground in my area. All of our clients go to Spokane. And then we also had another question that asks, can you speak to why this work is not statewide? Why are some counties not by current contractors?
Those are great questions. For the individual who is inquiring about interest of getting a PCAP set up in their area, please feel free to reach out to me and I can navigate some of that with you directly. Long story short, I guess for that is that Spokane, I don't know how close you are to Spokane exactly, but I do understand that Spokane does go out of their county even just by a little bit to serve clients in surrounding areas. And they are one of our contractors that we're currently working with to expand client slots with the DCYF, effort that I had mentioned a few slides back. They are growing, and I know that they do serve clients outside of their area a little bit, but if there's like a significant distance between you and them, I'd love to talk with you and see what we can come up with in terms of support. The question about, I think Shalia, is the second question.
That's
Can you restate it?
Can you speak to why this work is not statewide? Why are some counties not covered by current contractors?
Yeah, great question. So this is a really unfortunate response. I don't know that, like, even I don't love the fact that a lot of our contracts really can only be provided when funding is available. And the funding isn't necessarily available consistently enough to just set up everywhere statewide. So we set contracts up in new service areas when the funding is available through LEDGE. And so we are working on it. It has been a slow process. Like I said, it began in 1991. We started with King and Pierce counties, and slowly since then, when funding has become available, have been able to set new contractors up with the serving PCAP services in different areas across the state. That's like the shorter answer of it, that it's really dependent on funding. There's also some concerns around how the program needs to be operated and eligibility of staff that provide those services, and maybe serving in more rural areas. It becomes more difficult to stand up a program and stabilize a program with all of the needs that are there in order to get a program more to make a program more successful long term. So we've just, there's a lot of complexities around it, but ultimately it's related to needing the funding and finding the right staffing and keeping them. I know that's probably not the most fun answer.
Thank you so much, Sarah. We appreciate it. I don't see any other questions at this time, Sarah, but if you're okay with it, just as before, if we get any other questions afterward, are you okay if we send them your way?
Absolutely. I welcome it.
Okay.
And I do want to make sure we make a point. In the ICM program, there is that language that if somebody is receiving targeted case management services and Medicaid funding, that you can't also be receiving ICM. So as Sarah said, PCAP does receive Medicaid funding, and then also it's a targeted case management program. So if you have somebody that's in PCAP during MSS, it's okay, but they would not be eligible for ICM, as that's duplicative of services. And so sometimes I know in the past, some providers have provided ICM, and then when those units are up or have been used, then they may refer to PCAP after those units have been used, as a way to kind of try to get more services to clients. But just wanted to make sure that our ICM providers are aware that you can't have a family that's in PCAP also receiving ICM, because that's in CMS's eyes and the federal government's eyes, that's duplicative, because it's very similar services since they're both targeted case management only programs.
Thank you, Heather. That's perfect explanation. Thank you so much.
Thank you. Wonderful. We will transition now to our updates and reminders. In just a moment. Right, so we do have a few program reminders here. So HCA, the agency, is moving to electronic submissions only for prior authorization request. And this does include the limitation extension requests, the LERs that are submitted. So if you providers or agencies need any additional training on how to submit requests directly through Provider One, please let us know. We're happy to meet with, whoever your team, provide any sort of help and assistance on that. We don't have any, I don't believe we have any date yet as when that will take effect, but we will definitely keep you updated on that. ICM covered services. So just as a reminder, we've been seeing records where we're seeing non-covered services are being provided for ICM. So just know ICM is a targeted case management program, and covered services include screening, case management, care coordination, referrals, linking the client and parents to other services or resources in the community, advocacy for the client and parent, follow-up contact to ensure the care plan continues to meet the medical, social, education, and environmental needs of the client and parents. Again, so ICM does not allow education, counseling, or interventions for risk factors. All right, and I will turn it over to Heather.
Thank you. And I noticed, and I don't know if you'd be able to click on the hyperlinks, but the hyperlinks are missing from this page. So when we send out the recording and the PDF document, all of these updates and reminders will have a link for more information. So a lot of this information is thankfully on HCA's website. So just wanted to make sure that you're aware of that as well. So just in a few days, I can't believe November's already here almost. But effective November 1st, the income limit for Apple Health for pregnant individuals in the after pregnancy coverage, or APC, will be changing from 193% to 210% of the federal poverty level, FPL. And so what that will mean for MSS and ICM is that, well, actually it's more, I guess, MSS, those who are pregnant and postpartum, up to 60 days for the First Steps MSS program, there may be an increase in those who are eligible because of the FPL increase going from 193% to, again, 210%. And that was thanks to our legislature who passed Senate Bill 5580, which we'll give a little update here in a moment. But that was part of that bill, was to increase that FPL. A doula update. HCA has a doula specific website. So if you're interested in learning some more about doulas, you can put in hca.wa.gov and then do a search of doulas, and it should pull up where you can click on the doula website. During the 2024 legislative session, Substitute Senate Bill 5950 passed, and that directed Healthcare Authority to implement a doula benefit for Apple Health Medicaid clients, which includes a Apple Health birthing doula reimbursement and is design and recommendation for a doula hub and statewide doula referral. So things have been moving. CMS has approved our state plan amendment. And so the target implementation is early 2025. And the January webinar that we will be hosting, and I believe Shalia has a slide that'll have that date here in a little bit, will be talking about the birthing doula benefit at the Healthcare Authority, as well as some information in regards to midwifery. So the statewide recommendation that birthing doula services be available to birthing families in Washington was recently signed by both the Department of Health and the Healthcare Authority. And then I don't know, Shalia, if you have that to share or not, but I can make sure to include that letter in the documents that we send out with the recording. And that the reason for the statewide recommendation is so that a physician or an OB or a midwife doesn't have to refer someone to doula services. So like MSS, people can self-refer. This helps with the EMS requirement that anyone who is interested in receiving doula benefit or doula services in Washington State can do so, as long as that birthing doula is certified and has signed a contract with the Healthcare Authority. Thank you, Shalia.
You're welcome.
Yeah, so hopefully you guys can see the chat. She's put some information in the
And these will go out afterward as well, but I did put links into what we've been talking about too. So Sorry, Heather. Go ahead.
You're all good. Um, so the next update is in regards to a really long. As you may be aware, in March of 2024, there was the second engrossed second substitute Senate Bill 5580. So Senate Bill 5580 had started in 2023, and then it didn't make it through that session, and so it was brought back to life in 2024, and then was signed and by Governor Inslee in March. And so Section 2 of that bill requires that the Healthcare Authority make updates to MSS, such as updating the current screening tools to be culturally relevant, include current risks, as the tools have not been updated since 2008, ensure that the tools address health equity, and include questions identifying various social determinants of health that impact a healthy birth outcome and improved health equity. The bill also requires that HCA develop a mechanism to collect the screening tool results and evaluate the program. And then the big one, to increase the units and reimbursement rates. So many of the changes that are required in the 5580 bill will take place beginning January 1st, 2026. However, one portion of the bill that we are currently working on is putting the current screening tools into an online system so that we can collect the results. We have begun collecting contact information for those who are interested in helping us to test the system. I believe we spoke a little bit about this at the last webinar, and then Shalia put it in the October quarterly newsletter. And so anyone who's interested in kind of helping to test the system, please let us know. And I believe one of the slides will have our contact information. Also, we were very fortunate to be able to, we were accepted to be able to work with a University of Washington Doctor of Nursing Practice, or DNP, student. And part of her work will be conducting a focus group to collect feedback on the current MSS screening tools. More information to come on the focus group in the near future, as she's just begun kind of working with us. If you would like to be part of the focus group, please email us as well. So just to be clear, that the focus group is different than those who will be testing the online system. So please let us know if you're interested in volunteering to either test the system or be part of the focus group, that you really specify which one you're wanting to volunteer and help us with. And then last but not least, I think I briefly talked about this at the last webinar, but it was kind of, I don't think we had as much time. So I just wanted to bring this to the forefront again. The telemedicine or telehealth billing guide was updated mid-June of 2024, I believe. So this last June. So effective June 6th, audio-only telemedicine visits require an established relationship between a healthcare practitioner, which would include an MSS or ICM provider, and an Apple Health Medicaid client. And then an established relationship is defined within that guide, and it's defined as the healthcare provider providing audio-only telemedicine. Has access to sufficient healthcare records to ensure safe, effective, and appropriate care, and the client meets at least one of the following. So at least one in-person visit, or at least one real-time interactive HIPAA compliant, that audio-visual visit with the healthcare provider providing audio-only telemedicine, or with someone who is employed at with the same medical group or within the same clinic within the last 3 years, or referred by another healthcare practitioner who has met those requirements that I just said, and has provided relevant medical information to the healthcare practitioner providing audio-only telemedicine. So kind of pretty much what it is the first visit either needs to be in person, and that in person can be in the office or in the client's home, or face-to-face through the computer, a HIPAA compliant audio-visual telemedicine visit. And that again began June 6th. So if you're going to provide audio only, there does have to be that first visit there has to be a visit prior to providing audio only in person with the client, or for ICM with the client and their parent or parents.
Thank you, Heather.
I haven't been watching the questions. Any questions anyone has?
Do you have one question about the doula services, asking if it will ever cover postpartum doula as well, or an option to be able to do postpartum versus birth doula?
So the birth doulas that will be approved are able to cover are the services doulas. The birthing doula services are pregnancy through the 12 months postpartum. So the definition we're saying birthing doula, and these need to be birthing doulas who are certified through Department of Health. So it doesn't mean that they're only doing just the birth. It does allow for that 12 months postpartum as well.
Thank you. I do have a question. I will answer this one. It's asking if there is any increase for reimbursement for ICM units. Not at this time, unfortunately. But we're always working on making program improvements. So it's definitely something that's on our minds as well, but not at this time.
Yes, and that too, like MSS requires legislative approval. So unfortunately, that wasn't part of the bill. It was specific to MSS.
Yeah. I don't see any more questions. I do want to add that our next quarterly webinar is January 23rd, and we will be covering the doula in a lot more detail at this webinar. So that'll answer a lot more questions too. So it'll be a good one to attend.
And to also put in a little plug, I was part of a 3-year midwifery through the Institute of Medicaid Innovation, I think it was. There were 5 states, I believe, chosen to be part of this group, and Washington was one of them. And so as part of the midwifery work, a survey was completed with midwives who accept Medicaid, and then also with Medicaid clients who received at least one visit with a midwife. And so part of the webinar, along with the doulas, we're also going to be sharing some of the results from those surveys that were completed with both the midwives and the clients. So put in a little plug for that as well, especially for those of you who are big into data.
Did have a few more questions that came in. Is there already an existing training for the LER submission, or will one be available?
So we had done one, we realized ages ago. And so we do have the slides for that, but if anybody is interested, Shirley and I were speaking that if we get a good number of providers who would like training, a kind of a refresher on that, or even just are new, and we may do a special webinar for that, or if we just get a few that are requesting it, we might do something specific for your agency if you're interested. So we can definitely send you the slides now, but we can set something up in the near future to make sure that because I know sometimes it's easier to talk things out.
Yes, definitely. All right. It looks like maybe that is all of the questions that we have.
I see the one about, can you email the audio only telemedicine information, please? And that's actually on the billing guide on HCA's provider billing guides and fee schedule website. So if you go to that, you should be able to find that under the, if you pass by MSS, keep scrolling down to the T's under telehealth, I believe, and you'll find it there. And I think I can put in the hyperlink.
Yeah, when we send out the information after as well.
I'll put this. Oh, wait.
Oh, it looks like we had a few more questions that came in. Okay, my understanding is that the eligibility for MSS is 90 days after birth for postpartum mamas and babies to receive MSS. Can this eligibility term be extended?
So MSS actually ends 60 days postpartum. So, and then after that, ICM begins. So What we have been approved for through CMS is the 60 days, and then also MSS was not included in the legislative language when the after pregnancy coverage was written. So currently it's at the 60 days, and I don't think there's any discussions currently because of the federal requirements that we have, and we need, again, legislative approval and requirements in order to extend that.
I have a question. The next webinar is January 23rd, and we will send out a Gov delivery also. And then Heather, I have another question. The in-person first visit is now required. So basically all the enrollments must be in person.
Yes, if you're doing audio only. So before an audio only visit can take place, the first visit needs to be in person, face to face, or through the computer, face to face. And that was changed June 6th, 2024 within that telemedicine billing guide. And that is because that's a legislative requirement. And it's for right now, the way the language is written is within the within the last 3 years. And also it states that if it's within the clinic. So if you have somebody, say like you have an OB clinic that has an MSS within it, or even just a doctor's office, or just something you've maybe seen the client, your clinic has seen the client before, that counts as having been seen face to face. So it doesn't say it's specific, just MSS. It's kind of looking at that clinic or that group, provider group.
Thank you, Heather. I don't see any more questions. Did you have anything else to add?
Nope, just if you're interested in volunteering to be part of the focus group with our DNP student, or if you're interested in testing out the online screening tool system, let us know. We're hoping with the online system, maybe doing a soft rollout, hopefully maybe in the spring of 2025. But a lot of that will kind of depend on the testing.
We just got a few more questions that just came in. Does WIC count for face-to-face?
So if there's records showing that they have come in for an appointment, a visit, my understanding is that's what's required. So it says at least one in-person visit with the healthcare provider providing audio-only telemedicine, or with a healthcare provider employed at the same medical group or the same clinic within the last 3 years. So if that WIC provider is employed at the same medical group or same clinic within the last 3 years, and there's that documentation that they would have, then my understanding, the way that the language reads, is that would qualify.
And I think that answers the other question of, does the doctor in our clinic meet the requirement for the first in-person visit?
Yes.
So that would, all right, wonderful. All right. And as always, if you guys have any additional questions after the webinar has ended, you're always more than welcome to email us. We're here, so we appreciate it. So.
Oh, and so another question came in. Where would you document the info? So I'm assuming WIC, as part of their rules, requires that there's documentation. So if there's ever monitoring or records being requested, then those documents would need to be covered. So if your agency is considering the WIC staff as a healthcare provider employed at the same clinic, then it would qualify. If there's something they're not considered that, then it may not qualify.
Thank you, Heather. Now I'm just waiting to see if any more questions pop up.
Yes, this can be confusing, and there is, like I said, there's the telemedicine guide, and I don't know if there's an email within it to ask questions. Because we do have someone here who's kind of the SME, the subject matter expert for telemedicine questions. So if you guys do have any questions or anything, definitely send them our way, and then we may send them to her. If her email is not listed within that guide.
Yeah, let me check and see if it is. Let's see. Hmm. We will definitely include this in the information that we send out as well. All right. Well, if we don't have any additional questions, we can wrap up a few minutes early, but we really appreciate everyone listening in. And Heather, anything else before we end?
I don't think so.
All right.
Oh, sorry, Lynn. We just got a question. So that email that's up there, the HCA First Steps at hca.wa.gov, if you're interested in being part of the focus group or testing, send us an email through there and just let us know what you're interested in, please.
All right, everyone. Thank you so much.
Have a great afternoon.
Well, yep. Have a wonderful rest of your day.
Thank you.